My talk is on identifying or diagnosing the pelvic discontinuity, and probably this forms a platform for your next two talks where the reconstruction of pelvic discontinuity will be spoken about. So pelvic discontinuity is the most deadliest situation in a revision hip replacement. As we all know, revision surgeries are gradually increasing. By definition, pelvic discontinuity means loss of structural integrity between the superior and the inferior part of the pelvis. So if you see the epidemiology, 1 to 5% of revisions are done for pelvic discontinuity. Risk factors are female patients, rheumatoid patients, or history of radiation for some other reason. When the bone quality is not good, these are the patients are more prone for pelvic discontinuity. And the causes are chronic non-united stress fractures, trauma. Post-trauma situation is very common to have a pelvic discontinuity, infection, extensive acetabular reaming. One of the few cases Dr. Ramnik showed and many other speakers showed. Excessive reaming causes pelvic discontinuity, and impacting a cementless shell in a very hard way breaks up the anterior posterior column and the medial quadrilateral plate. That is iatrogenic pelvic discontinuity. You see the pathophysiology, we divide the pelvic discontinuity into acute pelvic discontinuity and chronic pelvic discontinuity. Acute is usually following a trauma situation. Iatrogenic, as I mentioned, over-reaming, trying to get a cup supra-inferior fixation and reaming of the anterior and posterior walls was one of the most common cause for iatrogenic pelvic discontinuity. And ruthlessly or impacting your cementless shell very hard into the medial quadrilateral plate causes a pelvic discontinuity and periprosthetic stress fracture. Most commonly, acute pelvic discontinuity, bone opposition is good, healing is normally good. It is like an acute comminuted fracture, healing is usually good. In contrary, chronic pelvic discontinuity, gradually because of the periprosthetic osteolysis and osteopenia. This is a deadly complication. Usually there's a lot of fibrous tissue at the lysic area, and the bone edges are sclerotic, non-vascular. Healing is very difficult. I'm sure this is the cases where require a distraction technique, which the subsequent speaker will be telling about that. So Papyrowski classification or double AOS classification, whichever classification you take, the last one would be the pelvic discontinuity. Either it is Papyrowski or it is a double AOS classification. The last one would be the pelvic discontinuity because it's ultimate thing to reconstruct the situation. If you see clinical evaluation, the most common patient complaint is pain during weight bearing. If the patient is complaining of rest pain or night pain, we should suspect something else. In a pelvic discontinuity, classically pain during weight bearing. And if you have a history of previous surgeries or previous implants or scar at the operative sites, definitely you know that it is a post-operative pelvic discontinuity. So always you have to be clear. You should rule out infection when you are thinking of pelvic discontinuity. Rule out infection, ESR, CRP, and suspected. If at all you are suspecting infection, aspiration is a good idea. And as far as your diagnosis, you must know the relevant anatomy. I'm sure you know the ilium, ischium, and pubis. You must know the anterior column, posterior column. I'm sure you all know from morning we have been talking about it. Whenever you have an anterior column break, posterior column break, and the medial quadrilateral plate break in all the three components, then you call it as a pelvic discontinuity. If you see radiological evaluation, well-centered AP view, most of the time we are able to pick it up. But if you have a suspicion and you're not able to do, iliac view and obturator view is very good. And Lekesne view is the one which can diagnose if you're already having an implant, a cup in place where you're not able to diagnose your pelvic discontinuity. This view is good. I'll tell about that. So signs of pelvic discontinuity on X-rays is one of the cases Dr. Vijay sir showed. Visible fracture line should be there. Obturator ring asymmetry, medial migration of the inferior hemipelvis. That is one of the cases Dr. Vijay showed. Medial migration of the hemipelvis and disruption of the Kohler's line. So if you want to see the anterior column and the posterior wall, that obturator oblique view gives a view of anterior column and the posterior wall. And if you do an iliac oblique view, you will see an anterior wall and the posterior column structures. So sometimes these X-rays is not very contributory. So when you take an X-ray, you should see that for the teardrop, change in the teardrop, iliopectal line, which indicates the anterior column or the pelvic ring problems, or ilioischial line, which creates, it shows us the posterior fracture or the central acetabular fractures. So these are the obturator views. Obturator view, you will see anterior column and the posterior wall. And if you see a iliac view, you will see the posterior column and the anterior wall. So when you have an implant like this, that is the Wilesnack view I was talking about. Supine view when the patient is tilted to 65 degrees and take a view, that gives an image of the medial side of the acetabular component. In case if there's a discontinuity, you can pick it up. In one of the studies, 11% of cases of pelvic discontinuity was not detected preoperative radiograph when they went for revisions. And 31 patients' radiographs were found unreliable, only plain X-rays were unreliable. So this is a special view which you have to do 65 degrees rotation to see the medial side of the acetabular component to diagnose your pelvic discontinuity. So sometimes lateral view also helps to diagnose a pelvic discontinuity. The most important gold standard is CT. We all know CT scan is very, very important. That is very effective to identify the osteolytic lesion, pelvic dissociation, and column deficiencies. 3D CT reconstruction, metal artifact suppression software achieves the reliable 3D reconstruction also with the presence of hip orthoplasties. Even in the presence of implant, CD is the gold standard to diagnose. 3D CD modeling is ultimate. That is the best thing to diagnose your pelvic discontinuity. Last two slides I have. This is a patient with a fracture dislocation of the hip joint. It looks like it's only posterior wall, but on oblique view, we are able to diagnose the pelvic discontinuity and fracture reduced. And when you do a 3D reconstruction, anterior column, posterior column, medial quadrilateral plate is broken. This is acute pelvic discontinuity. Second one is an elderly patient had a fall. You think it's a central fracture dislocation. When you do a 3D CT, we will be able to diagnose a pelvic discontinuity. The management of it will be in the next talks. To take home message is multiple images, different views will help you to some of the time to diagnose things. You need to check for iliopectial and ilioischial line, obturator rings. Special views may be required like the false profile view. CT scan is the gold standard. Wherever you have a chance, you need to do a CT scan, and 3D modeling will help you to diagnose a pelvic discontinuity. Thank you.